kind of the stand and said to the judge, I said, I don't think this case has been proved yet. So it's not an uncommon, it's not an unusual thing to see this. And it's also not so unusual to see patients who plop down in front of you and say, oh, I've had asthma for years. And then you go to look to see where is the objective evidence, and there is none, which I think I'm imploring you to get. So, does she have airflow obstruction? Is there reversible obstruction? Remember, we talked about how you can use bronchoprovocation testing to look for asthma. If it's negative, it's part of the definition, so she probably wouldn't have it. So, virtually all patients with asthma have hypoxemia during acute exacerbation, for what we said. The more severe the obstruction, the lower the PaO2. It is very unusual to see, here's a little pearl, very, very unusual to see severe hypoxemia with asthma alone. It just doesn't happen. The PaO2 of 70s, 60s, yeah. 50s, I get a little nervous and worried. And beyond that, it just isn't asthma. So what's the pearl? Look for something else. That patient doesn't just have asthma. Usually, the PaO2 is not that severe. Do they have pneumonia? Do they have pulmonary embolism with it? Or maybe it's not really asthma, and so forth. So I think that's just somewhere. So O2 tension is certainly less than 50 are rare, and when seen, the degree of obstruction is severe, with extremely severe CO2. And probably a blood gas would show you, in addition, hypercarbia. So here's the VQ this much. We talked about, obviously there's a lot of reasons why her ventilation was diminished, giving you alveolar hypoxia, and as her perfusion would be fairly normal, she does have a large AAO2 gradient, and hypoxemia is usual. Here is the mechanisms of respiratory failure with asthma. You get a low ventilation perfusion ratio, low alveolar O2, and increased AO2 gradient, and this gives you a low, what I say, decreased O2. Okay, but think about this. There's also areas where, because of hyperinflation and air trapping, there are areas in the lung that you can breathe in but can't breathe out so much. You get some air trapping in various areas of the lungs. And when these air trapping occurs, what happens to the vessels around these airways? They get compressed. So you actually get a high V, low Q, high VQ areas, and a lot of wasted ventilation. And increasing wasted ventilation means that you're breathing, but you're not gas exchanging. It increases the work of breathing, and CO2 production increases. Muscle fatigue eventually ensues, and this causes an increased PCO2 and eventually respiratory failure as increased CO2, decreased O2, and asthma. I believe this woman had something that's called vocal cord dysfunction. Now, I will tell you an interesting story about this. About 15 years ago, we saw a series of patients like this. One or two of them had had factitious diseases with it. One young woman I remember had factitious fever. She would take her thermometer and she would put it up to the lamp, you know, to the light bulb, and then, and she was, you know, obviously very psychiatrically disturbed with kind of a Munchausen's type of presentation. So we presented this, and we published an article called Factitious Asthma, saying that these patients didn't have asthma. They had wheezing that I'll describe to you in a second, but they didn't really have asthma. 3 months later, another article came out, same patients, same whatever, and the author from Denver called it vocal cord dysfunction, as if there's something really dysfunctional with the vocal cords. Well, 15 years later, I still don't believe there's a vocal cord dysfunction. I think these people have strong psychiatric illness. I think it really is a conversion kind of reaction where they're, and some of the patients we described, one was a young girl whose father was in the VA hospital on a ventilator for months and months and months. She happened to be a respiratory therapist also. and she came in with this vocal cord. So usually there's something in the history of some stress psychiatric disease, and I still think this is very often a factitious disease. But we do call it, and the literature's called it, they picked up on this vocal cord dysfunction. Paroxysmal attacks of dyspnea and wheeze, rarely nocturnal. That's a key here. Most asthmatics have problems at nighttime, not during the daytime. But these patients sleep comfortably. Their utilization is high. 29% of the patients described in this larger series from National Jewish Hospital had been previously intubated. And this woman I just told you about, when we got her old records out, was in other hospitals in the state, intubated. There have actually been cases of tracheostomy in some of these patients who actually have this so-called vocal cord dysfunction. Now, what this syndrome is, and I'll bet you a nickel that you've all seen it, may or may not have recognized it, is patients with extremely high asthma utilization. You know, you get them on the ward, and you look back on the computer, oh, they were here 6 months ago, oh, they were here twice last year, and so forth. So their utilization is very high. Now, you know and I know that there are some really bad asthmatics in this world, who really are in and out of hospital. And some of them really just have horrible, distressing, sad disease. But not all. And I implore you to look for this diagnosis. So how are you going to tell? Well, the first thing is that some of these patients look, like this one, look so horrible when you're confronting the patient. Looked like I was ready to crump, didn't it? I could do that pretty well now. I've been practicing. You know, it's funny, but I did this to my fellows, oh my God, maybe 10 years ago. And I said something about, you know, I've got this asthma condition. This is before I gave this talk. I said, I have this asthma condition, and, you know, so I know a lot about asthma because I've been reading so much about it because I have the condition. And, you know, when I get a little, you know, nervous, sometimes I have a little asthma thing, and I just haven't been feeling too well. So you'll forgive me if I started doing this, and I sat down, and I was looking at these guys were like, I know. But it's not, it looks like I had asthma, didn't it? So the wheezing is often, when you inch along, one of the things that you get suspicious is that wheezing is sort of is loudest over more central airways. Now, that's dangerous to call it just on that, because remember, larger airways transmit sounds better than smaller airways. And as you were saying before, sometimes with bad status asthmaticus, you know, the lungs are so overinflated, there's so little air movement that there's actually a quiet breathing. So you may only hear a little bit over central, but at least it gives you a suspicion. Then kind of take that stethoscope and start to wind your way up into the neck. And very often, you know, you're like this, because a lot of noise is coming from the larynx itself. Now here's some secrets. First thing you want to say to the patient is, all right, I want you to do this. I want you to stick your tongue out. No, stick your tongue out, all the way out. And while your tongue is out, I want you to pant like a puppy, like this. Now, in doing that maneuver, what you're doing when you're panting is you are automatically opening your larynx. That's how you, I mean, it's not cognitive, you know, you don't try to open your larynx. This is just something that, when you start to pant, that's what happens. All the wheezing goes away. So, clue number 2. You hear this loud wheezing here, you have the patient pant. Next thing, imagine if the last patient you saw you admitted with asthma, okay? They really had a lot of air hunger. Can you imagine in a million years those patients holding their breath? No way! Status asthmaticus. Vocal cord dysfunction? Just hold your breath for a second. Okay, breathe. Status asthmaticus can never hold your breath. This disease, you can hold your breath. And then there's one last thing you do. Say to the patient, I'm going to be back. I've got something that I wanted to give you. I've got to go get it. I'll be right back. And you close the curtains. Okay? Now, you just left that patient. IV running, respiratory therapist has just been in the room. Maybe she's on her nebulizer. Looks awful. You close the curtain, and you tiptoe away. Okay? And then you peek. You'll look behind the curtain. I'll bet you'll see a patient, a lot of distress. First time I ever did this, I said to the fellow, I said, let's go. He said, she looks horrible. How can we just leave? I said, you're just going to leave. So we tiptoed back and looked in, and she was doing her nails. She was not very concerned. So really, this is, you see this when you're there and when you're not there, and you're peeking and you're sort of, trying to surreptitiously kind of look behind the curtain to see whether the patient has it. Often, this will go away. Again, giving you that sense that this is a dysfunctional vocal cord problem, not really a status asthmaticus problem. So, other findings: objective, gas exchange is normal during the attack. Expiratory flow may be normal, but variable effort is common on the spirometry, and something called a sawtooth pattern, which I'll show you in a second, makes the diagnosis. And of course, in an outpatient, this is the problem with this young person who I saw in Connecticut for the judge. She never had spirometry, and if it was normal, then you do the methacholine. And if it obviously was negative, then you know this is really vocal cord dysfunction. So in an outpatient, when they're, quote, not having an attack, you bring them in, you do the spirometry, and this is the way you make the diagnosis. So this is often what this is obviously what a normal flow volume loop looks like. I'm going to show you a lot of flow volume loops this year, so you sort of get used to looking at them. Just remember that what we're looking at here is, this is a spirogram, the same thing as a spirogram. But what we're doing is we're simultaneously looking at flow and volume, okay? So the patient takes a deep breath all the way in here, okay? Blows it out. This is something that's called the peak flow, okay? Exhale, exhale, exhale. As the air gets less and less and less in the lungs, you go down then to residual volume here. So this is the total lung capacity, the amount you have, and this is, you can't blow out anymore. Then you take a deep breath in, and blow again. And that's what the flow volume looks like. This is a normal flow volume. Let me show you what this patient's flow volume will look like, and you'll be able to see a big difference. Okay. The first thing is when you're looking at you should get the report and say, I want to see the loop myself. The computer actually gives you the points, which is normal for this patient's age and gender and so forth. And you can see that she didn't quite do so well the first time. But look what happens during inspiration. That's just the vocal cords that are just, going back and forth. The second thing you see here, is we said do it again, is the variable effort. Okay? One time it's good, one time it's bad, the third time it's good. Again, this variable effort shouldn't happen in obviously normal people. And that's what a flow volume will look like in these such patients. So, how do we make a diagnosis? Well, since this is a vocal cord problem, this is the way we make a diagnosis. So you bring a patient with a little flexible laryngoscope, only this long, to look down the nose, and you can see adduction of the vocal cords during inspiration, or actually throughout their whole respiratory cycle, during these asthma-like attacks. So normally, if you take a deep breath in, the vocal cords open, they adduct. But here, during inspiration, you see adduction of the vocal cords. Let me show you what it looks like on a picture. That's you and I, normal during inspiration. See how wide the vocal cords are. This is your epiglottis over here. We slide over the epiglottis. Now remember, the patient's looking at us. We're the way I used to do bronchoscopies and laryngoscopies. I'm sort of facing the patient. So this is anterior, and the vocal cords open up during inhalation. Here's the trachea somewhere down there. And here is this patient. And this is not normal. So during inspiration, the vocal cords didn't really open. Matter of fact, all you see is this tiny little hole back into here. So this is an abnormal look, and this is what vocal cord dysfunction looks like, and that's how you make the diagnosis. And here during exhalation, you saw these cords aren't even open during exhalation. Now how patients do this, I don't know, but I guess the way I did it. So this is a differential diagnosis. Theoretically, if you saw somebody with a laryngeal problem, you'd worry about polyps and laryngospasm and anaphylaxis, etc. So what is this? Well, I don't think anybody realizes, but most of these people have a very strong psychiatric history, and this is what you do. Now, so acutely, if you're seeing the patient, one of the other things you can do is ask the respiratory therapist to come in, give him Heliox. Remember, helium is a less dense gas than air. So if you're making this noise with your larynx through turbulent flow, and if you suddenly reduce the density, the patient has absolutely no turbulence, no noise, and the whole thing goes away. The other thing I did once, which was a little hairy, but I had confidence, is I asked a nurse to give me some lorazepam, which I gave IV. And the patient was sitting there, and they're like ready to, the fellows and the residents were like, they were standing there with a tube, and the patient was, that was the end of the attack. So sedation is another way. One of the tough parts is that there are asthmatics who also have this, and that's a nightmare, because how do you know how much is asthma and how much is vocal cord dysfunction? But that's time for another talk. Okay, so just going to summarize. The major functional abnormalities of asthma are, remember, reversible airflow obstruction, which you can see on the spirometry. Remember, a 12% improvement of FEV1 or a 200 cc marks reversibility. Doesn't make the diagnosis of asthma because there are other things that can be reversible, but this is a typical and classic of asthma. Remember, remodeling of the smaller airways. We talked about that last time. I showed you how